Welcome everybody, and Stefan, thank you. You're available to translate today. Ti'n mynd I fod yn cyfieithu I ni. We have a number of people joining us online, so please can you let me know if you can't hear or you need us to speak up or you want to contribute to the meeting, and I'm sure Non here will give me a nudge as well if I miss anyone. The meeting is being live streamed today and it's also being filmed so that it's available for people to watch afterwards. So I'd like to call a start to the meeting. So just to confirm the process for asking questions, if around the table we can put our hands up, please, and similarly on the screen. I'll take a note of who wants to speak and then invite you in to speak. And as I say, if on the screen I miss you for some reason, then just give me a nudge. So I've received apologies from David Cogan, who's the patient representative. Are there any other apologies, please? No? Okay. So I'm also pleased to welcome a number of attendees today. Katrina February was the audit lead for Audit Wales. Welcome. Stefan, as I've said, who's translating for us. Ben Lejakari Olusunde, our aspiring board member. So thank you for being here. And this is your second board meeting. Good. Susan Miles, Director of Health Technology Wales, is joining us for item 4.1. And Alison Ramsey, Director of Finance and Corporate Services at NWSSP, will join for item 4.2. And Rachel Savoury, Head of Programme, Advanced Therapies Wales, may join for item 7.6. So that takes us, have I got everybody on?
Yes.
Yes, good, excellent. So that takes us into declarations of interest. Are there any declarations of interest not recorded? No. In that case, I'm going to take us into the minutes of the previous meeting. So if I'm going to take us page by page. Just speak up if there are any corrections. So we go for page 1, 2, 3, 4, 5, 6, 7, 8, 9. No corrections, all correct, so we can ratify those minutes. Thank you all very much. So let's go on to the action log then. So I'd like to invite us to consider and confirm the actions marked in the log. So the actions to close are, let me see, there aren't any. Oh yes, here we go. Propose to close action 3.3, which is a correction on the BAF. Yeah. Anything on that? No. Propose to close action 4.1, Public Audit Committee highlight report, and 6.4, which is the WIBBS annual report. We all content? Yes, thank you very much. In that case, I'll turn to the executives to discuss the status of the open actions. The first of which is 7.1.4.
Yep.
No,
I'll take this one and I'll speak in Welsh. So first test of our system. Fe welwch chi bod pwynt gweithredu yma wedi bod ar agor ers cyfnod hir. Yr hyn ni yn I argymell nawr yw bod ni yn gwneud yn ystyried y pwynt hwn ynghyd destun yr adolygiad mwy cynhwysfawr fydd i ddod ar terms of reference ar gyfer pob un o'r bwyllgorau y bwrdd fel rhan o'r adolygiad pellach ar strwythur y bwrdd a'i bwyllgorau.
Any questions for Noel on that?
I just wanted to welcome that, you know, the recognition that this has been an outstanding action for some time, and the kind of assurance that giving it focus now that it has means that we'll get to conclude it. I just wanted to check if January 26 does now appear to be the realistic time frame for that, or should we be, you know, what I wouldn't want to see is that there's continual deferral, but more would prefer there to be a realistic deadline date for it. So just wanted to check that out, really.
I think I want to say yes, but I can't confirm that. So if the board is happy for me to come back and review that, I will certainly have an update, if not a completed action on that. So it's our intention to move as quickly as possible with that review now. So I will confirm timescales in that context.
Yes, thank you for raising that, Lindsay. And I think it's important we get this right. And I'd like to thank independent members for the meeting that we had last week to discuss some of the immediate actions in terms of the committees. That's being written up for us, and we will certainly move ahead quickly with those things. But there may be a longer term piece of work as well, looking at the committees as a whole. Thank you. And thank you too for the executives who are working with the IMs on those committees. So that relationship is really, really important. And I'm really pleased to see the way that those relationships are evolving and developing. So thank you very much. So the second open item is 3.1, which is the performance management framework. Anne, can we come to you for this, please? Thank you. Thank you very much. And then we have two actions for Sarah. Action 3.1 and 4.4.
In terms of the first regarding PADR, we've got a positive trajectory in terms of that, and some additional information has already been provided within the PMF. Equally, now we've taken the decision to create a digital interactive dashboard, which will allow us to really make a step forward in terms of the way that we manage that. That will take us some months to build, but is the right direction of travel to enable the organisation and the board to have the right drilled down information. We made steps around that. Yeah, happy to move on. And in terms of the Welsh language update, there is now an SLA in place to ensure the board papers and simultaneous translation. We have got one outstanding issue regarding telephony services within BCS that we're working on a plan of action to address that, which is why it remains open.
Thank you. Any questions? Gareth.
Diolch, Cadeirydd. Roedd yr weithred yna ynglyn â'r iaith Gymraeg yn cyfeirio'n benodol at cyhoeddi y parau'r bwrdd yn Gymraeg cyn o cyfarfod. Ydy hynna yn mynd i gael ei ddelio gyda yn yr adolygiad yma hefyd?
Diolch, Gareth. No?
Dwi'n mynd i siarad yn Gymraeg. Ydy, ac ni eisoes wedi bod yn gwneud gwaith ni'n cnodi rhwngom ni a sefydliadau eraill o fewn NHS Cymru. Fe wnaeth, os gofiwch chi, y grŵp Governance Assurance a Risk gyfarfod a thrafod y mater hwn, a fe drafodon ni ateb sybl ar gyfer hyn, enghraifft bod papurau cyflwyno yn cael eu cyflwyno yn ddwyieithog, a bod eitemau mwy cynhwysfawr i gefnogi y papur cyflwyno ar gael yn Saesneg. Mae hwnna yn arfer o fewn NHS Cymru. Ac yn sgwrs byddwn ni yn cael fel bwrdd gweithredu i ystyried sut byddwn ni'n gallu cyflawni hynna. Ond y gwaith ni'n cnodi yw'r blaenoriaeth ni wedi bod hyd yma.
Thank you. Is the board happy to note the agreed status of all the actions? Yes, thank you very much. So we have one matter arising, which is the cancer patient tracking list data update. And I'm going to invite the Chief Operating Officer, Anne, to present on this, please. It's a very, very important development for us.
To see you read, I'm just going to bring out a few comments. Firstly, I want to have a shout out really to Carl Taylor's team, who have played a vital role in helping us get this along with some of my operational team. And the purpose of the cancer PTL really is to help us identify the unknown unknowns. And what I mean by that are the patients referred from the health boards to ourselves, who until we had the cancer PTL, we didn't have complete visibility of all those pathways. So this is critical for us as an organisation. And really further strengthening when we move in with the support of DHCW and we implement something called hospital initiated referral. So we have electronic referral from the health data set into Velindre. The date for that is the 23rd of February next year. It slipped slightly due to capacity in DHCW. So I'm just going to quickly go through slide 2 of 10. This is here just to show this is focusing on the single cancer pathway. So patients who are on a 62-day pathway, if you like, being referred. Massive percentage of our patients in total. It's about 25 to 30%. And that's how it breaks down. This is based on a 3-month period of data. We started having data coming through and 3 months trying to validate the data because of the data quality issues that were there. If we go on to slide 3, it shows each of the tumour sites, each of the health boards, and at what point of their pathway, on average, patients referred to Velindre. That information is broken down a little bit more in slide 4. You can see the range, you can see the tail, you can see the site with health boards on collaboratively. And then we can see that we actually, if we receive patients before day 38, we treat them within time largely. We have some small improvements to make, but that is a known cut-off point between a cancer unit and a cancer centre based on practice within England. And that's what we've spoken to health boards about so that we can move into a position where we have shared breaches across pathways and shared accountability across that 62-day pathway for the patients that we care for. Slide 6 gives a little bit more information about that. Slide 7 sets out the next steps that we're working with the health boards on. Slide 8 is a visual of the resources that are available to us and that we've offered to health boards to ensure that we move to a shared PTL. First step is that we've been able to give health boards their patients that they refer to us so they can see their patients that we're treating. And we would like to get to a point whereby we are using the same methodology and we have the same visibility of those patients consistently across all health boards. Slide 9 is about the dashboard and the views that we should be able to get going forward. We're working on that. That's still a work in progress. And it just leaves me to say, any questions, I'm really happy to take questions.
Thank you. Thank you very much. And thank you, Carl, for working on this. It's been a huge undertaking and continues to be so. Vicky.
Thank you very much. And thank you, Anne, because obviously the PTL is absolutely essential, isn't it, to the work that we're doing. I guess the big bit as a flag for me when I was looking at the table, particularly slide 3, which was that the other health boards, urological pathway is red across the board. And I just wondered what national work, linking in with what you were saying about a shared PTL, that we can quickly do, because that was of significant concern, wasn't it?
Yeah, no, good question. So the urology pathway was also flagged as part of the MAG report from last year. So what we've agreed across Southeast region is that we're going to do some bespoke work, use urology as the prototype, do a shared PTL with all of our providers or all of our health boards locally. We're also talking to Swansea Bay and Battersea about sharing some of the principles so that we're truly working in a collaborative way. And I think one of the other options is how can we do a kind of a bespoke piece of work, which I've spoken to the national team about, where we map the pathways and the resources that we have for each of the health boards and think, well, how can we choreograph those steps in the pathway to optimize the our capacity and minimize the patient journey.
Lindsay and then Jazz, please.
Yes, thank you. This is really useful information, and I think it really illustrates how data can improve our understanding of situations and help us plan around that. I think for me, there's slide 5 that demonstrates the improved timeliness, if you like, for patients referred to us within the 38 days is quite stark. That, you know, that is a huge kind of difference. And there's a couple of things in that for me, just wanting to understand what does that tell us that we can try to start doing to change that, so that we're getting more people referred to us within the 38 days. What are the barriers, and how are we working with the health boards around that? And also just to understand, is the point from suspicion to treatment, is that at the point of screening, results for screening, or is that at a later stage where it's kind of more confirmed that is that somebody most likely has cancer? Do you know what I mean? Because I'm aware that there have been and continue to be in some areas massive delays from screening to actually getting seen you know, within a health board services. So just wanting to understand that kind of bigger picture around that.
In terms of that last point, the point of suspicion is not the same as the point of referral. And those are the two differences we have, really, well, two of the differences that we have between England and Wales. So point of suspicion really is down to clinical judgment. And I think the conversations that we've been having across Southeast Wales is, do we need to set some internal professional standards that actually say when that is? If I compare with England, the point of referral is from screening. Once you're referred from a screening centre into a cancer pathway, that's the start of that. It's not the same in Wales.
That's really helpful. Thank you.
Yeah, sorry, Lindsay, just remind me which.
It was really recognising that it makes a big difference if we get the referrals within 8 days. What are the barriers? What do we understand yet? What we can do about that?
And I think we've got very strong metadata in Wales. What we're struggling with is this granular level of detail. So we know that there are barriers to some diagnostics. What we don't know is the numbers around those things. So this will allow us to, in a proactive way, manage that going forward. I think there's also to get to 38 days, you have to do the diagnostics, you have to get the results back, you have to have a conversation with the patient, they have to have gone to NDT, and there has to be a management plan. So I think that the 38 days is going to put a pressure on us to do those things sooner. And prostate is a really good example of within urology where we can start to make those changes quite quickly, I think.
Jazz and then Andy.
So it follows on from your point, Lindsay, really about, you know, what are we going to do about it? And I suppose the reality is that we've not been able to see this data in this way. And the power of it is to firstly interrogate it and understand what are the component weights within those days. Is it radiology? Is it radiology? So breaking that down into kind of more granular information is going to be really important. But also we are serving this region, and so our patients coming referred to us. I mean, look at the variation across the region. That's the first thing that is stuck, and to some extent unacceptable for us. So because what we're trying to do is improve these outcomes. And I think we have been challenged, but, you know, in a sense by government to say, well, what are you doing about it? And I think that we've just not been able to really be, you know, tactical, because we've not been able to know where we needed to target. And so it is just reinforcing the value of this work and the data, and now being able to get into the next layer of information. I think the other point I was going to make was just reminding ourselves this is first definitive treatment for Velindre data. We might need to put that in the slides in terms of it being in the public domain and not confusing people with this is the weights across Wales for cancer treatments. You know, I think we just need to be mindful of that. So I think we validated, we sort of characterized the context of this data. Thank you.
Andy and then Lauren.
We welcome this. I think what you're saying is February should be at a time when Velindre and Health Board partners will have access to this kind of live dashboard. Is that right?
In February,
It's on slide 8,
we will have a very secure data transfer on every single patient that's being referred into Velindre. That is, the data quality is much more assured. There's a lot of work that goes into managing the data quality behind this at the moment. The dashboard, i.e. the information that we can pull together and glean, and it allows us to do the business intelligence behind the cancer pathways and therefore make the improvements. We're working on that separately. So I would hope that we would have that in place by January, but it will definitely, the quality of the data in that dashboard will improve in February.
Lauren.
I just want to expand slightly on one of the things I mentioned around the focus on the impact, the focus on the Ministerial Advisory Group, the MAG implementation that we're having in the regional Southeast Cancer Programme Board. So, I mean, to give a couple of examples, so that it's the MAG report is really clear on in terms of the 5 most common tumour sites in Wales. It identifies the highest impact action for outcomes for each of those tumour sites. So the breast pain pathway, the postmenopausal bleeding, the symptomatic fit, lower GI, and those highest impact actions and the implementation of those for our 3 health board in the region is getting really specific focus. We're reviewing the data and the impact of that then on outcomes for our patients in the Southeast. And I reference it briefly in the partnership paper later, but I think it's something that as that work continues to develop in the regional boards, into the regional committee, that we can share some of that here at Trust Board as well.
Anyone else?
Yeah, can I just add one point?
Carl.
Yeah, no, thanks. So just bringing it back to where Anne started, really, first of all, well done to everybody. I think the point I wanted to add really was we have our IQPD meetings quarterly with Welsh Government, and we were able to share this level of granular data. Integrated quality and planning and delivery meetings, the quarterly meetings where we're essentially held to account for our performance by Welsh Government, which leads into then what was the JET meetings, which will now be the CAPSEC meetings. But I think what was extremely helpful, as Jazz mentioned earlier, for the first time, I think we were able to actually say what's happening where. So until reasonably recent, is a bit grey, but now we have the data which describes exactly where patients are in that pathway, which allows us then to act rather than second guessing. So I think it was very helpful. We shared that with Welsh Government. Nick Wood and colleagues there, and they were also really, really complimentary of the great work that's been done by the organisation and the region. So it's going to make a big difference, very big difference.
Yeah, well, thank you, everybody. And, you know, it just shows really how much of a difference we can make to people. This is, you know, people's lives, and the role that we've got to play in working with our partners. And it's making me think that we should consider how we maybe have some sort of seminar or development session for the board where we think a little bit more about what's going on in this space, and you know how we work with partners and so on, because it's just so important. So thank you very much. Thank you, everybody. So that takes us on to the chair's report. And the first thing I want to acknowledge is that there have been some changes within the organisation since we last met. And Carl here on my left has taken up the role of Trust Interim Chief Executive, and Jazz has taken up the role of Deputy Chief Executive. It's been obviously, you know, quite a big change for the organisation, and I want to acknowledge that. And I want to thank Jazz and Carl and everybody around the table for your professionalism. And I think the previous discussion just shows what we need to be focused on. I'm very happy to take any questions on that, but I think there have been messages to staff, so I'm not proposing to say any more on that now. However, in the spirit of the previous discussion, we topped out the new hospital last week, which was a real milestone in terms of the developments we're making for South East Wales and for people with cancer and those who care for them. And there is a brilliant opportunity for us in doing that. And actually, I think most people have been to the site, but if you haven't been, just go, because it's brilliant. And we should also take our partners there and the people who've invested and put their faith in getting that business case across the line, and getting us going. And I'd like to welcome Kerry. Kerry is our new independent member, and I'm absolutely delighted to have you here, as are all of us. And I know you've been getting stuck in, going to various meetings and committees, and we're now up to full complement on independent members, I think, for the first time in many years. So Kerry, I'm sure a lot of people will want to speak to you, get to know you, and you know, I'm sure they will extend that invitation to you as well. So just feel free. I'm sure I'm speaking on all your behalves, but you know, just feel free to go to anybody and talk and ask and just get to know people. So welcome, Croeso. Lovely to have you here. Kerry's learning Welsh as well. And Kerry, can I share about do you want to share about your son, your connection to us? I didn't ask you beforehand.
No, just, John and I were had a fabulous afternoon, I think it's fair to say, up at the Welsh Blood Service with your colleague Alan. Yes. Yesterday afternoon. Sorry, it's like first day at university, isn't it? What's your UCAS number? I can't remember anyone's name. And I had a particular interest because my youngest son, by all of 10 minutes, as I have twins, had not only been a stem cell donor once, but twice. And what John and I had the honour of looking at the map and seeing where bits of my son had gone to across the world. So yes, no, it was wonderful to see it. And yeah, I'm sure John and I'll talk to you as well about how impressed we were with some of the things that we saw there. So thank you, and thank you all for the welcome. I am going to forget everyone's name,
yes,
so
fine.
apologies.
We should all wear badges.
I'm a woman of that
Yes,
age, so
yes,
there is no other excuse.
Yes.
But, yeah.
So Alan, I hope you heard that, and thank your staff for hosting. Thank you for hosting, and the personal connection that we have with you. So thank you.
Thank you. Perfect.
So are there any questions on my report? No? In that case, I'm going to hand over to Carl.
Okay, so thanks, Chair. So first is an apology. So mine is going to be a verbal update. As you can imagine, it's been fairly busy the last couple of days. So I'm just going to add to a couple of things the Chair's already mentioned. Just sticking with Welsh Blood and Transplant Service, I think Alan, myself, Peter and a number of colleagues went across to the the NHS BT in Filton on the 6th of October. I think that was a really helpful conversation, Alan, wasn't it, in terms of a couple of things, really, our strategic opportunities individually and together, but also then we started to explore with them how we really start to get into far more helpful benchmarking. So I think that was time well spent, and we got a couple of things we could do together, we think, in terms of strategic developments and potential growth opportunities. The second sort of area we want to explore and set up was up at Neville Hall. So a number of colleagues were with us. We opened Neville Hall radiotherapy unit officially on the 16th of October. So colleagues were up there, and it's fair to say that it was a really good morning. The sun shone, but more importantly, we had really great feedback from staff, patients, and generally everybody in terms of life, so on and so forth, who have been involved in that project. And again, back to it will make a very big difference to patients, because what we do know is many patients do not take up radiotherapy treatment because time to travel is one of the constraining factors. So it's really good to see that. And also we've learned a huge amount in terms of what we can take forward when we commission the new Velindre Cancer Centre. So it was really, really good. And the feedback continues to be very positive. The third area is around success. And I think last week, the Velindre Cancer Service won a couple of awards at the NHS Wales celebration. So we won the Safe Care Award for the South East Wales Immunotherapy Toxicity Service, which is a huge achievement, and also recognising our move towards ATMPs, genomics, so that toxicity increases. So getting ahead of that will be fantastic. And then secondly, in partnership with Cardiff and the Vale, we also were successful in securing the Effective Care Award, which was for home diagnostic point of care testing for palliative medicine. So again, working in partnership to deliver real benefit to patients. I suppose the last thing I just wanted to update on, I attended NHS Wales Leadership Board on Monday afternoon, and I met for the first time the new Director General, Jacqueline Totterdale, and that was really helpful. She was very kind, very welcoming, and I've exchanged a few emails with Jacqueline, and I'm hoping to go down and meet with her next week. So that's a good opportunity for us to spend some time with her and just make sure that we are fully aligned in terms of what we are setting out to achieve and ensuring we're supporting the overall national agenda. So I'll just pause there, Chair, for any questions.
Any questions? No? Oh, you've been very busy, haven't you?
Well, everyone's very busy. So
Yes.
the team, yeah.
Okay, so I'm going to hand over to you to introduce the next item, please, Carl, the Quality, Safety and Performance Framework Report, and this is an item for us to note.
Yeah, thanks, Chair. So again, take the paper as read. Just a couple of things I wanted to bring to the board's attention. Firstly, an apology. There's a couple of typos in the paper. So if I can take you firstly to page 2 of 37, and it should read, basically it says, here to aid the QSP committee should be the board. So there's a typo. And then secondly, I just want to draw your attention to some updates in terms of which Lauren will take us through in terms of the levels of assurance for states and health and safety on page 3 of 37. Lauren will deal with that when she comes to the actual report. My second thing to draw the board's attention to, hopefully, is improvements. So what we have been doing, as we said previously, we've been trying to make the best of what we've got in terms of the current arrangements, and we've made some structural changes to the report, which we hope are beneficial. So what we have done, following the discussions last time around, Chair, we've put up front now about 30 quality KPI metrics we think the board would always want to see. So we will bring those forward at every single board meeting in QSP. So the things that really matter, the board always has sight on, and that will again be supported then by the existing arrangements for reporting by exception and all the other matters. And the second bit, we're working with the team, Carl's team, on another measure, an outcome measure for radical and palliative radiotherapy mortality within 30 days. We hope to bring that forward in the next meeting. And then if I go to performance, my general sense before I hand across to colleagues who will take you through each of the elements, performance and quality remains positive, not without its challenges quite clearly, but also always room for improvement. But you'll see through the document and the scorecard that I think, generally speaking, we are still delivering high quality care and services which have been well received by our patients and donors and our partners. So at that point, I'm just going to pass across to, I think, Anne in the first instance. Thanks, Anne.
So can I draw people's attention to the presentation, which starts on page 66 of 767, 71 of 773. Just to provide some context in terms of some of the changes to recording on cancer pathways. Everybody got there? Okay. So we've shown you the granular level of detail that we're now looking at. And it is because of some of that detail, we've been able to see how we're doing in more detail. The slide 2 of 9 sets out how the suspected cancer pathway, so the SCP pathway across Wales is measured. That has been in place since December 20. However, slide 3 sets out a change to that reporting that came into place in April 24. We weren't notified of that change, so we were unable to record or apply that to our pathways. We've since become aware of that, and we have validated that, and we are applying that to all of our cancer pathways now. The SCP pathway, the guidance is silent in terms of the subsequent treatment pathways, but we're applying the same principles as we believe that is good practice. So talk to the other cancer centres across Wales about that one. Slide 4 of 9 sets out the breakdown between the health boards and ourselves and who does what where, just to give you some context for that. And within SACT quality performance, the guidance is also asking us to prioritise patients into emergency, urgent, and so priority 1, 2, and 3 for the different treatment types. And we can say more about that. Slide 6 sets out the definitions for each of those treatment types. And we will be measuring our performance going forward against those for SACT patients. And if I come on to slide 7, what that does is it shows you the current performance if we were not using the validation, the new guidance, 7%. However, with the new guidance, it presents at 67%. That is a drop on the face of it. However, we are still treating the patients in the same way. It is literally how it's being recorded. Previously, for clinical reasons, one was able to stop patient pathways, so cancer patient pathways. And with the new guidance, the pathway continues regardless of the reasons, unless a patient is not available for 60 days or more. And slide 9 of 9 talks about the process that we're putting in place to ensure that Welsh Health circulars are being picked up and managed going forward. I'll just stop there for a moment. And, very happy to take any questions, and we can go back into the performance report with that context.
Question, Vicky?
I think it's really helpful because this triangulates with the QSP highlight report, because obviously it was a detailed discussion that we had in QSP on that issue. I guess for the trust board, for all of us, we need to know that actually the sort of national guidance being received within the organisation has got a specific channel to come through, because obviously this there was a gap, wasn't there, in receipt and the subsequent delays we've just outlined. So I think, you know, at the moment all the safety notices are received and they go through the integrated quality and safety group and reviewed then in terms of compliance. So it's just some assurance that actually we're going to be able to, not necessarily from just you, Anne, but from executive directors, just how we can ensure that we don't miss any future ones.
Shall I pick that up?
Yeah.
Yeah, I mean, we've done a lot of checking on this, and the circular was never received by the trust. That's one of the things clearly we will go back to government on. And then I might want to comment then on our process for managing and mapping. We've got a new process in place on anyway prior to this, about 6 months ago, Vicky.
Yeah.
This one was
And report that as well.
was never actually received by the trust, Vicky. So we've also, the other thing you might probably helpful to make the board aware, Carl and the team have also gone back through all of the other WHCs, because the next question I ask, well, if this is a gap, are there any others? So we've gone back through all of those cards from that.
Yeah, we've confirmed that we're doing the right things as far as we're aware.
Yeah. So that's just coming back, that's a matter you're going to raise with in your meetings.
Of course. Yeah.
Lovely. Thank you.
Gareth?
Diolch, Cadeirydd. Just i dilyn sylwadau Vicky, dwi'n croesawu'r broses newydd yma o ddelio gyda cylchlythyrau, oherwydd dyn ni wedi cael profiad yn y gorffennol lle ni ddim wedi gweld rhai yn nhw ac ddim wedi dilyn nhw, ac mae'n bwysig iawn bod ni yn cadw llygad ar hyn ar broses newydd yn y dyfodol i weld os ydy'n gweithio'n iawn.
Diolch, Gareth. Anyone else? No? In that case, I'm going to hand back to you, Anne, please.
We'll go back to the report now, and I sorry to keep you around here if you're so we're looking at it from page 36 of 767 to orientate people. And the radiotherapy waiting times. What we've tried to do here is have some productivity metrics as well as the performance metrics across the piece. Those productivity measures, as we go through coming months, we will build on and continue to do some more benchmarking so we can understand our utilisation rate as well as our performance. We have a LINAC at the moment, LA6, being upgraded. That will happen all the way through to December. We're running 2 of the other LINACs to offset that drop in capacity. As you can imagine, it's a bit of a challenge for the team to choreograph that. I'm not going to say any more about radiotherapy, except to draw your attention to slide 1237, which is really where our baseline going forward. We will be looking at that benchmarking piece, how the LINACs are functioning, what number of patients we're getting through each month, and the number of fractions as well. There's more detail that we need to feed into this, like tumour sites and what those some tumour sites require more fractions than others. So all of that nuance we need to bring out in the narrative. And the team are working on how we would do that one. The SACT performance, again, I'm open to questions, I think, on that one. WBS, there's good news stories in terms of stem cell collection and our recruitment to stem cell donors. Well, earlier, red cell stock levels we're managing. We've had no alerts. They're daily huddles. There's an operational pressures framework to help manage that across the piece. And in October, we have certainly put an offered mutual aid to England. The incidents have been driven really by errors factor, which we are trying to manage out of the services with increased digitalisation. But it is an institutional manual process of selection of donors and a lot of the laboratory techniques as well. Stop there.
Questions or comments for Anne, Vicky?
Sorry, just a couple
No,
if I may. I was really interested, and apologies that I didn't pick it up in but the prostate pathway in terms of reduced and decreased fractionation, then the potential loss of income that's associated with that, because on the one hand, we've got really fantastic research development and innovation resulting in improvements in treatment. And then we've got the financial risk. And I guess what I didn't see when I was looking through the BAF subsequently is actually perhaps that emerging risk in terms of the financial impact. So just how we're working through that, because you can see in the paper you're still working through that. It's just actually how, as a board, we start to see those risks materialise or mitigated.
Yeah. So actually, in part of the finance report, I referred to the gap between the investment we've had to make in the satellite centre, which gives us the capacity. Workforce planning around obviously setting up a 20% increase in your capacity in radiotherapy. It's a tricky business in the NHS or in any organisation, but trying to ensure you have the required level of staffing means you've got to plan 12 months ahead because recruitment times. So we're at a point now where we're largely established, although given the fact of the vaccination and the benefit that we get in terms of patient outcomes, obviously, in terms of not having to have as many treatments, there is the side impact of the treatment income dropping. Now, all the planning around the new 20% capacity type of fractionation. So, we're on a journey to create that capacity, and it will be needed over the next 10 years. But at the moment, we're grappling with that mismatch now between the investment we made in the staffing. We have held some vacancies once we realised that we weren't going to get to the income target we planned. But that is not offsetting at the moment the gap. Other alternatives, though, we have capacity available in that satellite centre. There is significant demand, as you know, across South Wales and West Wales. So in terms of the populations in West Wales, Swansea, Bath, there is an opportunity for us to open up capacity there, and also for patients in the west of England. So I think we need to be thinking about some of that, which is what we need to have the conversations and do some planning around and how we utilise that spare capacity in the right way and secure additional income to cover those costs. So that's where I think we're at.
Yeah, and just to add to that as well, at the moment we're obviously commissioning new kit, and we're also commissioning new planning programs. So we've got some of that resource both in radiotherapy and in medical physics that are supporting that as well.
Yeah, it's a very important area that we need to come back to as a board. Vicky, did you have a follow-up?
Yeah, it was, well, not a follow-up, it was just a second question.
Okay, go. Yes.
But thank you for the responses both. I think that what I picked up as well, the deep dive into the SACT improvement plan. How are we as a board going to see those sort of improvements month on month, given that sort of, much more detailed review of that SACT improvement plan? So will we, for instance, by the end of March, see a significant difference? How is that going to materialise?
We are recrafting that balanced scorecard for SACT, and we had our first meeting with the division this week to map what some of that would look like at a high level. There's the introduction in BCS of patient tracking list management processes, and how we build that into the operations. So we have our new general managers starting in next month in December. We will be introducing weekly PTL meetings across all the tumour sites, and that will cover all aspects of the patient pathway, outpatients and SACT. There's more detail going into the SACT PTL, which means that the booking team will be able to use that to manage the nuances in terms of SACT booking more accurately. We will have KPIs that we feed into the dashboard, and we will see the dashboard here.
Thank you. Lindsay and then Jazz, please.
Yes, thank you. So my first question possibly kind of cuts across a little bit what Matt was kind of referring to earlier, is in relation to it's again welcoming the data and having now the baseline around the utilisation, and so really pleased to see that. I think for me, there is then as we go forward with that, this is the starting point. As we go forward with that, it's the so what that follows, as we said earlier. You know, if it shows problems or benefits, you know, what are we doing with that? So wanting to see some of that narrative kind of would come in alongside that once we can see how are we managing against the baseline would be really helpful. And I just wanted to kind of highlight a really positive example under the time expired platelets, where we've had the lowest level in over a year, and recognising that that's the evidence of early positive impact of a planning tool developed through Data and Insight team. So just really welcoming seeing that, and obviously looking forward to seeing how sustainable that is as we go forward. But yeah, a good example of the difference and the so what.
Thank you. And I think the lens of the improvement workshop that I think you and Vicky attended, it's really helpful.
Yes, and I think, you know, Alan, thank you again. And I think there's some real things that we can learn from each other in terms of the way that you run those improvement workshops.
Thank you, Chair. Yeah, it's starting to really change the culture of the organisation. I think it's a cultural journey, and it's something that I think the staff have really grabbed hold of and are working with us. So I think it's a great example of where the service can take its ambitions, really.
Thank you. Jazz?
I think just to add to the WBS improvement piece, you know, it's just sharing with the board that we are leading on innovation, which has a global impact. I attended the Spotlight event, and we necessarily showcase some of that, and perhaps we should try and reflect a kind of report that just tells us the scale of that ambition, but the impact, and small changes, but with a significant impact. So yeah, absolutely validate that. I think the second point, just coming back to the SACT performance and changes in reporting, but also managing our expectation. It's going to take time and probably some months to have an impact on those figures and those trajectories. Reminding ourselves of where we were with radiotherapy, probably some, 18 months to 12 months ago, we had the sort of goalpost changed in terms of reporting, and it's taken us some time, but actually we've got some really strong reporting metrics for radiotherapy. That's partly because of ARIA being introduced and the systems that we've invested in that have enabled us to really target the weights and improve those outcomes. So I think it was this will take some time to impact. But I think the overall point of it is that, in a sense, what we're saying is clinically, it doesn't matter what the cause of your weight is. And it might be that you have a complication post-surgery, which puts an increased weight into when you can have your first SACT. But that's still relevant, because is that higher in Wales than in other parts of the UK? Question mark. And we need to understand that. So is that about our population's baseline and comorbidities? And unless we do that kind of, unless we actually assess outcomes in that way, we won't be able to make changes happen. So it seems painful in a sense for us at the moment, but there's a good reason why we just need that overall lens.
And that's very well described. Thank you, Jazz. I just had a couple of things as well. So in terms of the radiotherapy productivity, I assume we have a benchmarking element to that. So what should that, or could that productivity look like? And maybe we share that at another time in the interest of time. And the second thing was in terms of stem cell donors. I think the fact that the Welsh Blood Service has been able to increase the number of donors from minority communities to such an extent is just really, really impressive, because this stuff is very hard. And, you know, we've been talking about how we increase the patient and public involvement in our improvement work on the cancer side as well. And again, I think there's a lot to learn across the organisation, because we have some real expertise on patient and donor engagement within this organisation that we can pull together. So that just really struck me, and you know, it's really quite remarkable. And in fact, I shared that with the Cabinet Secretary, and he was really keen to come and see a little bit more around how that had been done. So thank you very much.
Okay, so if we covered off the main parts of service, I think pass to Nick in terms of quality, Nick.
So we've discussed a number of issues, there was just a few more things for me to highlight. So first of all, really positive, and that's sort of on the first table there, our infection prevention and control healthcare acquired infection rate, which is extremely low. And, you know, we are back in the trend that is being seen nationally in respect of healthcare acquired infections. So again, a really concerted effort for the teams to put patient safety first there. The second point was around the patient feedback, and one of the developments with the scorecard is that we will going forward be including the number and percentage of our patients and donors that have actually given us feedback as well, so it can be more firmly quantified. And really good story in the cancer service, as you will see from the quarter two quality report, is that within the cancer service we have increased significantly the number of patients who have given us feedback during the quarter, up to just over 900, which is about 130% increase to what we were seeing before. So further work to do, and you know, blood service always maintain around about 16-17% of donors providing feedback, which is really positive. So just been working with the cancer service and the new team there in how we continue to increase that. And the other positive is that, you know, we have had no public service ombudsman investigations commenced since quarter 3 of 23-24. So that, you know, just demonstrates the quality of our investigation and case management process here at the Trust. Thank you.
Any questions? No? Move on then.
Okay, thanks, Nick. So we're going to take across to our staff and workforce now with Sarah.
So again, starting with some good news, maintaining really good levels of our statutory mandatory training, and recognising we have an awful lot of training going on across the organisation in terms of really setting the context of our people strategy and wanting our staff to develop. From a sickness perspective, we're maintaining a slight reduction in terms of the national position, but recognising there's still a little bit of a way for us to go in terms of our aspirational target here within Velindre and reducing that. The teams are working with each of the services in terms of maintaining hotspot plans to ensure that we really focus on the areas that need the most support. And equally, in terms of the work we're going to do around the digital dashboard, which will allow much easier access for managers. One of the challenges we find in terms of managing these things is having the capacity and the time to do it. So we need to really make it easier for our managers to ensure that they've got that at their fingertips. Recognising PADR, since joining the organisation, I appreciate it's a hot topic for our board members. Fully agree with that, because it's incredibly important in terms of how we recognise our staff, develop them. We're maintaining a positive trajectory over the course of the last year. We recognise we still have some way to go to reach that target, and all are committed around that. In terms of our hotspot areas, which we're now throwing out, we have some plans working with services in terms of getting us to the space that we need to be. Equally, the team and I are now looking at ways that we simplify some of the paperwork that we've got around this, so that we make it easy to have good conversations. And another thing we will be looking at is about putting some of our development and learning on a digital platform to ensure we can access 24/7 help for any manager at any time. Happy to take any questions from anybody.
Questions? No? Andy?
on the staff sickness, which is stubbornly percent and has done for a long time, and we have our own local target and national target. We've discussed that before, and I know I've asked this before, but in terms of those relative to other boards, NHS organisations, and it's always interesting to hear, because I suspect we're in a similar place to others. But in terms of the organisation, can we drill down that 5% and look at different divisions and find out where those high levels of sickness are?
Yeah. So we can, and that information is provided through the divisional directorates.
Yeah.
And the team work within the divisions in terms of hotspot areas. Yeah. And we have a RAG rating in terms of that sickness that works throughout the organisation. We've equally now looked at triggers such as half pay, full pay, reductions, etc., to allow us to really ensure that we focus our capacity and capability in the right spaces in managing that. What I would say, particularly in terms of the NHS Wales position, we're doing well in sickness, but I think as a good thing, we have a stretch target in that respect, and that we should be striving to do that, because from a cultural perspective, we want to have our staff happy and healthy and work. Hopefully that answers your question.
Oh.
Yeah, I'll just add to that, because I guess I was just thinking as we were talking, I mean, there's the cause and effect, and the effect is 5%. But in terms of back to this afternoon's conversation about high performing organisations, culture, what's our offer? You know, we've got a clear position of want to be an employer of choice. So what enables us to do that? And then what would the effect be on? So I think these are all related, aren't they? PDRs, opportunities. So I think it'll be a good discussion this afternoon, because I think it's fair to say that our staff are absolutely committed, probably overcommitted, and sometimes that presenteeism. So I guess it's understanding if the system currently gives us 5%, unless we do something different, we're going to stay at 5%. What is it we get to the next level, which really gets, you know, so I think it'd be a useful conversation this afternoon.
Yeah, and I would say that the area of organisational culture and how we develop is very clearly something that we need to spend more time on as a board. You know, we've got these metrics which say what they say, but there's also, you know, what it's like to work here. And I think there's a lot that we can do to support the organisation, particularly as we're going through so much change and dealing with so many challenging external factors to the organisation, because I think this is absolutely central for us in terms of our own workforce and our relationships with our partners and our patients. Absolutely central. So, you know, there'll be a lot more in this space. Thank you.
Okay, so if there are no more questions, they will just go across to digital.
Yeah, thank you, Carl. I think I'll just make 4 quick points, if that's okay. The service continues to be in line with expectations. At the recent QSP, we did look at it through the other lens, though, to say, well, what's in the 15 or the 20% that's not getting done? It's generally around joiners, movers and leavers and kit. So that's where I'm asking the team to focus their efforts on, just to keep that continuing improvement. We're making really good progress with the move from Windows 10 to 11, which is a very important cybersecurity kind of feature. We're over 2,050 Windows 11 machines, which represents about 86% of the organisation, with the other 14% being supported by a Microsoft Enterprise Support arrangement. We'll continue to get security arrangements. We think that leaves us well ahead of the rest of NHS Wales in terms of that work. We have commenced the digital diagnostic. So we've talked occasionally about the capacity and capability of the digital team. We commenced that work on the 10th of November, with the readout expected to go to the Executive Management Board in January and then follow through here. So we're pleased with the great support we've had from our exec colleagues and the leadership from the organisation to help that. It's not something we want to do by ourselves. And I suppose the last point is about the significant incident. We did see one in September related to the blood establishment computer system for WGS. It was resolved, but it just, I suppose, re-highlights the importance of that programme to the Trust over the next 2 years.
Thank you. Move on to Lauren, I believe.
So as Carl mentioned at the start of the paper, there's been a change, a positive change in the level of assurance score, both for estates and sustainability from a 3 to a 4, and health and safety and fire safety from a 2 to a 3. So we talked through this in detail at Executive Management Board and then reviewed with Quality Safety and Performance Committee this month. The reason behind those. So for estates and sustainability, it's specifically around the performance of the plant preventative maintenance, which, as we know, is the most important leading indicator of effective operational estates performance and service sustainability. And then for health and safety and fire safety, specifically around the, as we've talked about in board, 2 cycles ago, the achievement of the training schools across the required levels for the first time in a number of years, and overall the management of the fresh risks and actions that are then reported for assurance in highlight report up to QSP, which has had positive feedback over the last couple of reporting periods. So that was on the overall assurance levels. And then just to also note that in QSP, we had a specific discussion around the sustainability of the plant preventative maintenance performance. And we also, I also updated on the deep dives that had been conducted over the previous period on both violence and aggression and the needle stick incidents, which were related to the 2 riddles in the reporting period. That's the more detailed discussion in the committee.
I should have also invited questions from Carl. Sorry about that. Are there any questions for Carl or Lauren? Be happy to note. Vicky?
I think just amplifying really the grip and control in terms of the PPMs, because I think, you know, again, this is targeted focused work and it shows the benefits and the outcomes from that work. I think QSP discussed the fire, because I think the low compliance for fire safety training continues to be an issue. But again, you know, we need a bit like the PADR, we need that sort of focused team level work, don't we, in terms of getting those adherence levels up. So that's just a comment on those 2. Thank you.
Thank you very much. And finance.
Thanks, Chair. So you can see from the slide a number of KPIs are reported, financial performance metrics. To give context, the current assurance level rating is 4 in terms of recent extent of our actions taking impact. Board assurance framework risk score of 12. So that's the current assessment KPIs that we monitor. There are 3 statutory KPIs: revenue balance, remaining within our capital funding limit. We're all on track to deliver in this financial year to date. Our agency reduction, which is part of the Welsh Government drive to obviously reduce expenditure. That also savings delivery, so those 2 feed into delivering our revenue. Well, put in context the trust position. So whilst we're planning and still aiming to deliver balanced position this financial year, across NHS Wales, there is a £191 million forecast deficit to the end of the year, across 5 health boards. That is creating just over 100 million pressure on the Welsh Government Health and Social Care expenditure budget. Clearly, there's a lot of work going on across the whole of NHS Wales, which we need to contribute towards in terms of aiming to reduce that gap significantly by the end of the year. I suppose the context for us, so whilst we're saying or three major pressures land this year, which at the moment we have no recurrent funding source for. We are covering off internally through non-recurrent income. But also the context of our commissioners being in significant deficit. Leads me into the next part, my update, which is planning for next year of 26-27. So that's the context that we're going to be moving into the new year. The Welsh Government have already stated, even though they haven't yet issued the formal allocation letter, they clearly been working hard and they've been discussing budgets internally in Welsh Government. But it's a zero cash uplift. What that means is there's no uplift. Normally, NHS will receive between 1% and sometimes 3% uplift based on budgets to fund cost pressures, service improvement. Welsh Government have not got that availability from UK Treasury. The settlement enables them to keep enough funding essentially to deal with all of the known pay inflation, other negotiated settlements who pay. That is what they're holding on to, the full settlement from UK government to do that. So that risk is at least contained by Welsh Government for us, but that means we then have no funding for all of the other cost pressures and service pressures, capacity investment requirements. So we're working through, as I said, our MTP planning for next year. It's a significant issue in terms of that gap between the investments we need to make, the cost pressures we already have, and the funding we're going to get, and the savings target we're going to have to set. So, for any questions?
Yes.
The detail of the finance report, which you see is appended, but obviously I could take questions on that summary and also on any.
Lindsay.
Yeah, I just wanted to kind of get a sense of your level of confidence around the savings target, because the differential between achieved and target savings has got a bit wider over the last few months on here, and clearly we will be getting figures for the subsequent months soon. Just want to understand, because it says it's expected to continue to deliver, but whether you think year end we will actually achieve.
I've got confidence that we'll deliver the target in totality. It's the mix between how we're doing that between recurrent schemes and non-recurrent schemes. So, and like all NHS organisations, there's probably a roughly 50% delivered through recurrent savings and 50% of the target through non-recurrent. Unfortunately, some of the recurrent schemes that we planned this year have not delivered. We haven't been able to replace with other recurrent schemes, but non-recurrent schemes. So I'm assured we will balance the savings target off with those schemes. But obviously that adds to what I've just described as the financial landscape for next year. There's an additional 250,000 of recurrent savings to be made next year. Savings target. You don't ideally want to be not delivering on those, but that's the reality sometimes, particularly around workforce and where you're trying to redesign a service or make savings through replacing one type of staff with another. Comes back to the sort of radiotherapy discussion earlier. It's a 10-month, year and a half trajectory to deliver some of those things, not in year.
Thank you, Vicky. And then
Thank you.
Gareth.
I'm just interested in what you put in the paper, Matt, about the commissioning group for cancer and the fact that it had been in the IMTP for this year, but there was no commitment in year and it was going to be put forward to next year. How much of a risk is that in terms of the SAC business case? Because that's obviously...
Sorry, I should have said we've already had obviously initial discussions with our commissioners, and given the Welsh Government statement of zero cash uplift, they've already confirmed one, given their deficit is 106 million more than what was planned this year. There's zero cash uplift. They've already told us there is no investment money for providers. That includes their own other health boards that provide services to each other, but also internally there's going to be limited investment in any of their services. Obviously, clearly a massive risk around all of those things I described: the capacity investment, the service development. There is no funding unless we can identify savings or productivity improvements where we can, deliver some of the increased capacity at no cost. That's where we're at.
So I guess because the reference is about putting it, rolling it into next year's IMTP, but equally the risk of whether that gets funded or not, as you've just described, needs to be profiled in the BAF as well, doesn't it? So,
right, yeah,
because I mean, it's one that's been emerging, and but I think we do need to see that triangulation.
I didn't. I started with our position around the level of assurance and the BAF risk score. I forgot to say, of course, based on what you've just reminded me, clearly we were having a conversation around that assurance level of 4, whether it actually may need to drop from that, but also more importantly, the BAF risk assessment of 12, in my view, will need to increase to 16. For the reasons I've just articulated, and that will be, I think, formally through the next cycle. I will be recommending that. I mean, because otherwise we're not sending the right signals. Like you said, triangulating through the BAF score and the risk score. To what I'm telling you verbally.
Yeah,
thank you. That we're doing. Sorry.
Really helpful.
Gareth.
Diolch, Cadeirydd. Rydych chi siarad lawer gwaith yn y gorffennol ynglyn â'r cytundebau tymor hir gyda'n comisiynwyr. A mor ffriog ydyn ni y gallwn ni gytuno egwyddorion comisiynu newydd gyda nhw yn y dyfodol agos, oherwydd mae'n broblem sydd yn codi o blwyddyn.
Thanks, Gareth. So it's not just a problem for Velindre, first of all, so the issue with long-term agreements and the historical nature of the baselines affects all of the providers. So that's all of the health boards essentially, and all the health boards that have contracts with neighbouring health boards and other health boards in terms of these issues. We have managed to at least get agreement from Directors of Finance through the good work of the deputies, setting up a group to review the baselines for LTAs. There is absolutely no prospect of change between now, I don't believe, and March, when we have to submit our MTPs for next year. But the fact that we've at least agreed that we need to have a group to work through how we're going to get a fair and consistent approach to rebasing. Because at the moment, part of the significant impact we've had as a trust is one health board unilaterally rebasing, which has lost us £1 million in income. Carl and I will be having discussions with Welsh Government about that impact and how it significantly affects our financial planning. They will reference, well, what work are you doing through DOS, and we can say that we're going to do that work. But in terms of a solution, it's not going to happen next year. Yeah, so it's going to, it's not the first time NHS Wales has tried to sort this problem out itself. I think we will be asking, well, I said we'll be asking Welsh Government for some assistance in this in terms of some leadership guidance and also support around setting those principles. I think it would be beneficial if, performance and delivery units help with some of this, being independent arbiters and getting us to a place where because it's difficult, isn't it, for individual organisations to take that view because they're statutory bodies, and they've got to attempt to do the best, don't they, for their own resident population. So trying to get a consistent and agreed approach across Wales does need some independent arbitration. I think rather than going to formal arbitration, that'd be more helpful, wouldn't it? We don't want lots of formal arbitrations, and nor does Welsh Government. So having them, I think, help shape the principles would be good for NHS Wales. I think we could do something about having a conversation with you.
Just to add to what Matt said, so we've Matt and I've worked this through. We've submitted sort of an email in the first instance, setting out our sort of sense. So there's 3 or 4 things we've identified, what I've determined on, can sort of said as structural issues, which go back some time. So the first is the SDEC money, same day emergency care. So that was funded, and it's been funded for 4 or 5 years. They are staffed, so I think we managed to get tactically more money last year. So we're going to pursue that, and we're also demonstrating, of course, in the overall system, it benefits the system because it helps to avoid unnecessary admissions and so on and so forth. So we're trying to pursue that one. We're also then picking up, Matt just mentioned the Hywel general issue about the LTA. That's another structural one. We think there's some, do believe objectively some real sense of, well, we need some support on that. And then we've got national insurance contributions some other bits and pieces. So we've sent some things down. Next step now is for Matt and I to go and meet with Howell, Jones and Samir, and then see where we get to with that. And I have made the new Director General aware that we're having those conversations with her team. So hopefully we will progress. If not, we'll have to find a different way to solve it.
The only other thing to say is the joint commissioning committee, which commissions specialist services, are also reviewing their baseline in terms of the funding that comes from the commissioners, which is the health boards, essentially, into that specialist commissioning committee. So they fund all that specialist services, but they're reviewing their baseline contributions. So I'm watching with interest that, because clearly I can't believe any of the health boards that form that committee now one individual health board to have a unilateral view on how they want to rebase it, and the rest of them to do something different. If that happens, there's a consistent rebasing. They will be using that as evidence to reopen conversations with Health Art, but also sharing with Welsh Government about, can we have some arbitration here without it being official arbitration, please? Because we don't want to go into that. None of us do. It's a waste of time and effort and resource, but some sense in the system around fairness. But it hasn't concluded, and I think it's because of the thorny issue of one or two health boards wanting to base it in one way, and the others wanted to do it in a different way because of the gains and losses. But the principle behind our original rebasing and what the JCC one is that there's a rebasing of funding to neutralise it in the year you do it, so that if a health board loses, it gets funding from the other ones that gain, and it moves around the system. And from that point onwards, it's real. And you have to bear the pain if your activity goes up, or you get the benefits back if your activity goes down. It's that neutralisation through our funding adjustment, the bit that we had signed up, we thought pre-COVID. COVID happened, we didn't implement the change, and nobody wanted to do it because it was all getting too difficult. So I just wanted to say that because it's important context with the JCC and where they're going, and Cardiff and Vale Health Board of the same. They provide a lot of the specialists.
Yeah, they do.
They have the same issue with commissioner health boards where they're not getting the recompense for the services they deliver in the right way, and they need that rebasing to happen. But it does need to be neutralised to give fairness, and then from that point onwards, you have to bear the pain of how you're managing this, your referrals and goes into those specialists.
It's really helpful. Thank you, Matt. John.
Apologies if it's a subject later on today. But just wondering, the conversations we just had around the changes in LTAs and the impact on all health boards, but particularly ourselves, how does that link in with the timescale? The next board is in January. IMTP process, I guess, will start very soon. So what's the urgency around getting understanding the options and how they're going to be discussed at board, and we can take this matter forward so we can better understand the actions that may be needed to be taken next year to keep balanced IMTP for 1 year and the 3-year period.
So in terms of what I've said about the LTAs, they will, I don't think it's going to change. So it'll be the rollover LTAs we've got. So for us, it's about what is the gap between the income we're going to get in from the LTAs, but also what's in our baseline funding, what the new cost pressures are for next year, therefore what gap does that present in the savings target, and what savings are deliverable. I believe we're going to be in a tricky situation. I'm not sure at this point whether we're going to have a balanced plan in year one of our 3-year IMTP, right? So it may well be that we're approaching government with the statutory requirements to balance over 3 years. So given a zero cash uplift in next financial year, we may well be in a position of having to say, well, we can't balance recurrently in year one, but we will do over the 3 years on the assumption that it won't be flat cash funding. There'll be uplifts coming in years 2 and 3. There's a limit the savings you can deliver as an organisation, as I'm sure you appreciate, depending on the size and the budget you've got, are already delivering above the minimum target set by Welsh Government this year. in terms of they set a target of what they expect in terms of efficiency and cash out savings, and we're already beyond that limit this year. To expect the organisation to go beyond that is going to be a struggle. So we just need to be honest with ourselves, but we need to have a wider conversation about this when we've done more of the work. So we're only at the early planning stages in terms of this information. Welsh Government will issue their formal budget to the health and social care and the NHS, from that in December. So in the next sort of few weeks, we'll have that formal budget from them. I don't expect it to be significantly different. I mean, I suppose the only things that might change if anything else comes out from the budget, UK budget, but I don't think so. What Welsh Government Treasury do have is a reserve of money that could potentially be distributed, or some of it be distributed, which hasn't happened at the moment. And part of the discussions, I suspect, in Welsh Government around budget settlements may well lead to some of that Treasury reserve in Welsh Government being distributed. So that may play in at a later date, but at the moment, the planning will be, I think, around a gap in our first year of a 3-year plan, which is the first time, I guess, for this organisation.
Absolutely, and we've got a discussion on IMTP, and clearly, you know, one of the things that we've all discussed and the IMs discussed together was, as being a short-term thing we need to do, is to look at how we increase the focus on finance, because it is a new place for this organisation, and it links very much into the culture work, because also the organisation is not used to that kind of environment and not used to understanding where we are in that very complex environment. So I think there are some issues here about our own governance and decision making that we have to progress really quite quickly to get to grips with that. And Matt, I'm really grateful to you for this paper because it's so clear, and it starts to bring up some of the implications for us. We are running behind, but this is a really important discussion. So, Carl, I know you wanted to come in, and then we'll borrow some time from now.
So I'll try and do two things. I just want to comment. Do you want to do the IMTV bit now as well? I'll talk about process. We can.
Why not?
Under 4.
Yes.
So
seems sensible.
So 3.3. Yeah, I agree with everything Matt said. I just perhaps also want. Some of this is within our control also. Let's not lose sight to that, you know, because I think, you know, if we just go back to what we're here to do, right care, right place, right person, right time. But I think we know that there is some way to go in our organisation, as across Wales, about getting to that. So what will that deliver for us? By doing the right thing more often, talk about reducing variation, all those things. So I think we all know there's opportunities there. The other thing we've got to make sure we do is realise the benefits from the investments we made in digital, in the infrastructure. So I think, you know, a lot of this is broadly within our control as well. So it's not all outside of our control. So I think that's the real focus, isn't it? To make sure we can do absolutely everything we can with what we've got, and then understand if there's a gap. So I think that's the job of work for us in this organisation. We can't do it without doing that with our partners as well, because these are about care pathways, aren't they, and so on and so forth. So I think it is tricky, but it is, you know, we flip it. It's an opportunity to get really great care, which the byproduct of that is it's more efficient, more effective, and those things should help us. Might not get us all the way there, but just want to balance it up in terms of, you know, there's an opportunity as well to do what we already wanted to do. Just in terms quickly of process then, cover this off. So where we are, we've had a couple of board development sessions. We've had various discussions at EMB. The draft plan is in development. A couple of important sort of timelines, picking up on John's earlier point. So we have a board development session on the 16th of December, where the team will be bringing forward these sorts of conversations, really, so the board can further understand it, because essentially then we'll start to make some choices, so on and so forth. The second point then is government are intending to issue the planning framework, the financial allocations and the outcomes framework on 19th of December. So we hope that will then solidify what we already think. I don't think there's going to be a huge change in what the expectations are for the next year. And then that takes into the other side of Christmas. We are hoping to have a decent first draft IMTP this side of Christmas, as we said we would. And then we've got EMB in January and SDC on the 21st of January. So I think, you know, we'll be in a decent enough position to really start to understand.
acronyms because I
Sorry, I do apologise.
Yeah.
No, I'm sorry. Yeah, so
The last two, so in January.
sorry, Kerry. So executive management board, so our exec team,
Yeah.
will have a first draft plan for the officers to consider. I think the 12th of January, and then we'll bring that to the strategic development committee, which is a committee of this board, on the 21st of January. So we then have 2 months before submission on the 31st of March to really understand, exactly where we're at and what choices we may be faced with. So that's what we're intending to do.
Are there any questions on that? Lindsay?
Yeah, just add an observation really. I'm just aware that one of the things that I've heard a couple of times from Jacqueline Totterdale is about wanting all health bodies in Wales to be curious, and in the sense of, why do we do that? Why do we do it that way? Why do we spend our money on this particular thing? So I think it really speaks to what you're saying, Carl, I think, about what's in our control and making sure that we are not just going with what we've always done, but that we are looking at, where are our efficiencies? Because I understand that her take is that there are efficiencies to be made, but without compromising patient quality and care, and in fact potentially improving. So it'd just be really helpful that we're building that into our thinking as well, and staying curious.
Yeah, I mean, Anne and Raz and Nick might want to make a comment on that in terms of clinically, because
speaks to the whole review of pathways and what can we do across the entire pathway with health board colleagues to optimise what we have, minimise the time taken for the patient.
Nicola?
Yes, to add to that, I think it is aligned with our digital clinical strategy as well, because clearly that's where the opportunity for some efficiencies occur, is actually doing things very differently, but use technology that's available to us.
So it can connect to our culture programme as well in terms of work, and when we give staff the opportunity to really think about what's the most effective way to help our patients, and that improvement lens, opportunities.
Yeah, they have. So this is going to be a real theme for us now over the next few months, and we've got to be very, very focused on this, and it does all align. The finances, our clinical care, our people, it does all align, and we have to make sure that our governance structures and the way that we keep on top of this also aligns. So I think it has implications for the next two items that we're going to be looking at, which is the risk register and the board assurance framework. And there will undoubtedly be some changes to this, but none. Please.
Sure. I will take the paper as read. I would just draw your attention to the governance route and some of the discussions that have taken place during the period at EMB and also at QSP more recently, to confirm that the target dates have been reviewed by colleagues around the table. I will stop there and provide you with an opportunity to ask questions.
Any questions on those two items? Okay.
Not so much a question. I've got some comments on particular BAF areas that I think is much easier to put down. But do you just summarise the risk one?
I did.
Sorry, I've jumped the gun. So, but in terms of risk register, there are a couple of comments that are where there are big drops from, and the one was a 20 to a 9. And we outlined that data migration across it, so about 3735. But that it started not fully in place. So I didn't know, it sounded a significant drop when the work has just started, I guess was my only sort of comment.
It's worth picking that up now.
And Matt wants to come in as well. So
that is a moving feast.
It is. So this is about the radiology system, the PAC system for the Velindre Cancer Service. I say our bit of the programme is going trust to go in mid-January, 19th of January would be our go live date. That is dependent on the health boards migrating 3 years worth of data into the new system so we can get access to priors. As Carl says, that's a bit of a movable feast right now. All the health boards have started. It's good to see. National programme have increased bandwidth to get more images through, those types of things. But as we sit here today, it's being projected for 2 of our health boards in the southeast would go beyond that 19th of the 1st. Programme are trying to accelerate, but not yet certain that we get all those 3 years worth of images to the system ahead of our go live. We are working closely with the programme team and our clinical colleagues to understand what that means.
Matt?
It's not a substantive point, it's a matter of accuracy. The appendix, this has got the detail of each of the risks on page 8 and 9. The new risk 3699, we just need to make sure the target rating impact and likelihood is 3 by 5. 15.
Yes.
And the target's actually 4.
Yeah. I will correct.
Yes, just an accuracy.
Okay. Anything else? No. In that case, we are going. Oh,
This is on this. I was looking at this 11 digital. This is faulty performance and service stability, lack of capacity to Wales. It struck me that there's target of 6 and expected date 31st of December, but there's an awful lot that still hasn't been done. It's just sort of a comment. I mean, this is about a whole range of digital systems which are listed here, and it just felt like that looked really ambitious. So I can't welcome a comment and clarification on that, please.
So there's 2 dimensions to the risks we're carrying around digital health and care Wales right now. One is the programmes risk we just talked about. LIMS, the laboratory information systems, is also in a difficult position for us, and some of the risks in the register reflect that. That is escalated now up to the CEO level at certainly the last digital and data technology leadership team, which has got the CEOs in there. Helen Thomas is the CEO of the ECW, is taking those positions there. So still quite a difficult position for us, but we are representing the trust wherever we can and escalating wherever we can. The second thing that we need from DHCW is to integrate our work locally into that national architecture so the data flows into the right places. And that does continue to be a challenge for us. So for kind of Ireland, there's a live FEDIS system, which is doing some kind of testing where we need those test results in the national architecture, and that is going slower than we anticipate. Capacity issues with DHCW. But we're escalating them to the right place. We're making sure that the right people are aware, and hopefully then starting to move through the clinical route as well. Because we take some of those through the digital route, we then need to go through the clinical and the kind of operational route as well, just to explain the risk around those. You're right. You know, I don't think we'll be clear of those risks by December.
No, and then there was a third-party supply Thermo Fisher. I didn't quite understand. Okay.
Thermo Fisher, this is in that integration bit. Thermo Fisher is our supplier for the new system for the transplantation labs and Welsh Blood Service. That system has passed UAT recently, so that's good, and it's in its validation right now. Had to move the integration for the Thermo Fisher bit, which is our supplier, into the national agreements into phase 2, because we couldn't get through the integration with the national systems.
so if there is anything that the board can do to support you in that escalation process and highlighting where some of these blockages are, then, you know, please do let us know. Anything else? No? In that case, we are going to just have a cup of coffee or a quick break. I can see that Susan, sorry, Board Assurance Framework, sorry, I was too focused on
I wouldn't want
the
Vicky not to have
break. Sorry. And my apologies, Susan, we're running a little bit late, as you can tell, but welcome. It's lovely to see you.
Thank you, no problem.
As well, colleagues have an opportunity to ask.
First of all, the summary on this back paper is really helpful because I think it's very clear what the work that's been going on. Assured by that detail, the overview summary paper is really helpful. There's a range of comments that I've got when I've gone through the detail in terms of all of the attachments that I won't go into now, but I think it's just to make a comment that for me, looking through some of the detail, is that there are gaps in the spaces where you'd expect action plan around assurances or action plan in terms of controls, and I've not seen it consistently. So rather than take up time now, I'll email in terms of all of the comments that are made on each area of the BAF to colleagues, and then hopefully we can.
That's immensely helpful. Thank you very much. Gareth and then Lindsay, or is it on this particular point?
It was just to say that was raised and discussed.
Yes, yeah, and noted in the cover paper too, so we picked that up.
Thank you. Thank you very much. Gareth?
Pwynt rwy wedi codi o'r blaen yw fod ynglyn â 9 o'r 11 risg, mae'r DF yn fflat, bod yn fflat am gyfnod hir o amser. Gyda un o'r risgau mae'r sgôr wedi dod lawr, ac gyda un arall mae wedi mynd lan. Ac y cwestiwn yw, os ydy'r duedd yn sefyll yr un peth, ydy'r camau dyn ni'n gymryd i ddelio gyda'r risgau yma yn effeithiol, neu ni ddim yn ei cario nhw mas?
Gai ateb ar rhan, fe gawson ni sgwrs fel bwrdd gweithredu ynglyn â natur statig y risgs. Dwi'n meddwl bod y sgwrs dilynol nath ddigwydd yn QSP yn cynnig creu o'r ddymatebion, ond rhai pwyntiau gweithredu sydd angen i ni fel bwrdd gweithredu i adolygu unwaith yn rhagor hynny di, ble mae gennym ni fylchau o ran controls ydy'r pwyntiau gweithredu i sicrhau bod rhywun cael ei cyflawni yn iawn ac yn ei lle ac yn cael ei gweithredu, a dwi'n meddwl mai dyna fydd yn blaenoriaeth ni nawr dros y cyfnod nesaf yma, cyn cyfarfod nesaf.
Ac edrych ar hwn, mae yna nifer o'r rhain sydd yn amgylcheddol, felly mae yna lot o ffactorau allanol, a fel dyn ni wedi clywed gen Matt a gen Carl a gen Ann heddiw, mae'r pethau hynny mewn rhai achosion yn dwysau, a mae angen i ni fod yn ymwybodol o hynny, na falle fydd hwn ddim yn mynd yn y cyfeiriad dyn ni eisiau iddo fe fynd, ond bod e'n mynd i newid y ffordd ydyn ni'n gweithio ac yn edrych ar hyn. Felly mae hynny hefyd. Anyone else? Matt?
I think I said earlier, and it is referenced in the summary at the beginning, that we will be revisiting.
Yes, absolutely. Yeah.
Sorry, just one other thing on the finance one, the target is down to 6, but I think the impact and likelihood is run the wrong way.
We'll catch up.
It doesn't make sense the way it's sure. Sorry.
No, that's fine. And if you spot those things, please give them to the team before. Yeah, that'd be great.
Yeah.
I don't understand the spot. Great.
I know. Talking of which, we are now going to have a break. So if we could just stretch our legs, get a cup of coffee and come back by, let's try and be back by 1:45, although that is quite ambitious. So if we're a minute or two later, then. Yeah, thank you.
Yeah.
through your annual report for Health Technology Wales. Thank you, Susan. I'm going to hand over to you.
Thank you so much. Good morning, everybody. I'm just trying to upload the slides. I'm assuming you still want me to do that, Kyle. I saw that you flashed them up earlier.
Thank you.
Yes, please, Sue.
Yep. I don't seem to see them coming up. Let me try again.
While we're doing that, can everybody online, are you hearing us properly? Or is there anything we can do to help?
Hearing you now.
Yeah. So speak up and get close to the microphones is the message, isn't it, Hilary?
Yes, it's quite difficult to hear people on the left as I'm looking at it, but so you're right hand side of the table.
Thank you. Okay, Susan, thank you.
Yeah, sorry, I'm just not seeming to be able to move on the slides. So, Olenka, have you shared the slides or is it me that's sharing currently? Apologies, I'm not entirely sure.
I think we are sharing in the room, Susan. Can you see?
I can, but I can't appear to move on the slides, which makes me wonder if somebody else has control.
Okay.
Yes, we do. So if you want to let us know when you want to move on, we will sort that for you.
No problem, that's ideal, thank you. Okay, thank you so much. I hope you can hear me clearly. So good morning everyone, I think it's just still morning. So thank you very much for the opportunity to present today on Health Technology Wales's work. Next slide please. So the presentation today, this brief presentation around 10 minutes or so, will reflect on the period 24 to 25 and present highlights from the Health Technology Wales annual report. Next slide please. So I just wanted to start with a quick flash of our team. So we're just a small team of 20 odd people, but you know, they're an enormously hardworking crew. And I just wanted to thank them in advance for their excellent work that we undertake on behalf of care services in Wales. So we're a mix of health economists, health service researchers, information scientists and programme staff that produce the outputs and the research work of Health Technology Wales. Next slide, please. I just wanted to also make mention today that Keith sends his apologies, but we've just appointed recently in the last 6 months a new appraisal panel chair, and that is Professor Keith Lloyd from Swansea University, and it's been a great addition to the team. So welcome to Keith, and I hope that he'll join me next time that we present to board. Next slide, please. So for those that are perhaps a little newer to HCW, just a very quick synthesis of our remit. So we were established in November 2017, and in fact it's our 8th anniversary today, so happy birthday HCW. And our remit is to provide a strategic, streamlined and nationally coordinated approach to the identification, the appraisal and the adoption of medical technologies across Wales. So consequently, our annual report is structured across these 3 pillars, as we call them: identification, appraisal and adoption. So next slide please. So identifying topics on which to appraise the evidence is a key part of our work, and in 24-25 we had 58 technology topics referred to us, and we've had over 550 in the 7 years up to this reporting period. Industry, the NHS and Welsh Government are our top 3 sources of topic referrals, with the industry referring just over 50%, and we continue to receive, however, a steady stream of topics from a range of different sources and from all across Wales, and this just gives you a flavour of where those come from. Next slide please. So evidence appraisal and reviewing evidence and producing rapid evidence reviews is the core of our work, and since 2018 we've produced 73 full evidence appraisals and generated 52 pieces of national guidance and 8 in this reporting period. I think we're at 60 plus now with the work that we've been continuing with this year. So these charts indicate that in 24-25 around about 3/5 or 62% odds of our national guidance recommended either routine or selective adoption of the technologies for which we praise the evidence. So selective adoption might just be where the evidence only supported perhaps in use of 1 or 2 indications or patient groups. And roughly 2/5 were not recommended as the evidence was insufficient to support adoption across Wales at that particular time. Clearly these figures vary year on year, but over the last 7 years this is translated into down to approximately 4/5 of our guidance recommending either routine or selective adoption, and about 1/5 where we do not recommend adoption because the evidence doesn't support. But I should say that our guidance is always a snapshot in time, and as ever, the evidence matures all the time, and we're always very keen to revisit our evidence if colleagues think that the evidence has moved on, such that it might make a substantive difference to our guidance. So next slide, please, just shows the range, or the diverse range of technology topics that we considered in 24-25. So everything from, very large patient populations and digital tools for diabetes management, robotic gynecological surgery, and a couple of AI diagnostic topics in prostate and gastrointestinal cancer. And our economists undertake regular resource impact analysis alongside our cost effectiveness modelling to understand the potential impact of our work. And they estimate that HCW national guidance is now affecting the lives of hundreds of thousands of citizens and delivering significant efficiencies and savings for care services across Wales. Next slide, please. So these next couple of slides are just examples, just to sort of, for those perhaps less familiar. This one's on AI in endoscopy. So we're increasingly being asked, as you might expect, to assess the use of AI in diagnostics and decision making. And here we considered use of AI in endoscopy, and we found it to be both clinically and cost effective, providing improved detection rates compared with standard colonoscopy, and supported its routine adoption across Wales. I think this topic came to us from Cardiff and Vale. Next slide, please. And another big patient population, we also supported the routine adoption for people with type 2 diabetes and a new digital platform that's been used in other parts of the UK called My Way Digital Diabetes, which allows people immediate real-time access to their scores, their trends, etc. And we found this, the evidence showed it to be associated with improved glycemic control, to be very well liked by users, and to be cost effective compared to standard of care ways of managing type 2 diabetes. Next slide, please. So patient and public involvement is really central in everything that we do at HCW. It's in all of our topics, and this can range from synthesising existing patient and public involvement research, from undertaking our own primary research. We've done that a few times for cancer topics with the help of Velindre colleagues. So we also conduct, for example, focus groups when there isn't research in the literature. We also take evidence reports from patient organisations and also direct patient testimonials to our committees. And the patient and public involvement group meets approximately quarterly, and they oversee and direct all of our PPI work to make sure that we're keeping on top of the topics and representing patients and the public at the very centre of the work that we do. Our PPI representatives are also full voting members of our committees, and they're integral in preparing our lay summaries of our guidance to ensure that our national guidance is accessible and understandable to all. Next slide, please. So after a number of years, we recently recruited some new PPI members, a new cadre, and these quotes were just from some of our exiting members who've been with us since the beginning, so 7 years, and it's been fantastic to really hear their fantastic positive reflections and feedback, and to have our PPI processes described as being world leading, and we're doing lots of international work, which is really gratifying and great to see. Next slide. So turning to the third area of our work is the third pillar, which we call adoption, and this is our adoption audit. So HCW guidance has adopt or justify status. So it's not mandatory, but there is an expectation from Welsh Government colleagues that the service follows the guidance, and if it doesn't, it has a very appropriate justification for why it's not done so. So to try to understand the uptake and impact of our work, we conduct a routine annual adoption audit to try to get to the bottom of that. In 2024-23, we audited 11 pieces of our own national guidance and 3 pieces of NICE medtech guidance, which is also of course widely used, and we work with the Welsh NICE Health Committee in Wales to do that. We had our best response rate so far. Procurement colleagues really helpfully provided all of the requested technology and the data that we collect for these technologies to help us triangulate the responses and understand the data. And this has enabled us to differentiate different levels of adoption and impact across Wales. And this was very important to the Welsh Government when they established HCW, because they really wanted to address that postcode lottery aspect and to understand was there equity of access to new technologies and to innovations across Wales, and also to identify lessons for the future from the work that we're undertaking. So the key results or key metrics indicate that awareness of our guidance was very good at just under 80%. Clarity was really excellent at 96%, i.e. the guidance was obvious to people and meaningful and easy to understand, and also was reported to have high impact in 72% of cases. And we also received helpful feedback on some of the barriers and enablers to the adoption of our guidance. So as always, of course, we're aspiring to being 100%. We're not there. There's room for improvement, but we feel pretty decent figures 3 years into the audit. Next slide, please. So some of the themes emergent in terms of enablers and barriers to adoption relate to, for example, uncertainties relating to implementation and funding of our guidance. There is still some residual disappointment with people fail to realise that actually we don't provide funding per se, that the funding for the technologies has to come within their existing resource envelope. So we're always trying to re-educate around that. And also some confusion in a few cases where we indicate partial support, and that's usually where we've said the evidence supports a particular indication but perhaps not another. And barriers in this last reporting period that were reported, and this is interesting because it's the first time really we've seen this, is funding and resources. So in the previous two audits we didn't find that resource access was a particular issue, but it was this year. Also small patient numbers was an issue in terms of developing national services within Wales, and also always some uncertainties about evidence and the interpretation of it, and still some limited lack of awareness in certain circumstances, which of course we're always working to improve. Next slide, please. So overall, in the 3 years that the audit has been moving on, we've seen steadily improving trends across the key metrics of awareness, clarity and impact. We're continually refining our audit method to improve process and engagement, and we work with an identified audit lead committee in each of the boards and commissioners, and we're working further to clarify where we make research recommendations to try to sort of laser in and focus on where the evidence needs to be better, and also to help people to understand the remit and focus of HCW guidance and its status, because sometimes there can be some confusion over where it sits, for example, alongside UK NICE guidance. Next slide, please. So this slide just really outlines some of the key actions which we produce every year to share with our main stakeholders who participated to continually improve the audit with the aim of optimising the impact of national guidance, really. And I won't read them all, you can read them yourself. But I just wanted to conclude on the audit by saying that HW's adoption audit work is leading in the field. No other HTA body that we're aware of, either in the UK or indeed across the world, have introduced a routine audit process to assess the impact of their guidance. But this novel approach really allows us to square the circle and understand both the impact of our work, but also its value to care services and how we can improve it going forward, because it's a lot of effort to produce this guidance, and we really want to be sure that people are making the most of it and able to use it and it's accessible, etc. And the next slide is just a couple of quotes from some of our key stakeholders, which just demonstrate the value of the work. Of course, producing high quality evidence appraisals and guidance is critical in our work, but ensuring that they're received, that they're trusted and that they're actually used in day-to-day practice to inform technology adoption and discard decisions is even more important. And our adoption audit work really helps us to do that in Wales and has received lots of international attention because it's a little bit different. Next slide, please. So just to round up, I just wanted to pick out a few additional activities that are either new or that we've been undertaking at HCW. So we remain a key partner in the Welsh Evidence Centre, which emerged out of the COVID-19 Research Centre, and we continue to produce high quality rapid evidence synthesis to inform general Welsh Government health policy direction and decision making. And so, for example, this year we've looked at topics on childhood obesity and using AHPs within neonatal care units, and this work is incredibly interesting and again very impactful. Next slide, please. In this period, we've also struck up a new UK level partnership with the National Institute for Health and Care Research. So as you've picked up, in the course of our research synthesis, we frequently identify gaps where the evidence perhaps isn't quite there to help to make an evidence-informed decision. So we always routinely shared them across Wales and with Health and Care Research Wales, but this new partnership with NIHR is allowing us to feed those research gaps back into the UK picture so that they can commission research that perhaps will allow us to revisit these topics and reassess the evidence at a future date once it becomes more mature. So that's been a new partnership and very, very helpful. Next slide, please. This year we've also been involved in quite a big international collaboration investigating the environmental sustainability considerations within health technology assessment methods. So as you know, the NHS has got the largest carbon footprint in the UK, and it's involved collaborating with 15 international HTA bodies across the world, culminating in an international white paper to consider methods to promote and understand environmental impact assessment, and to trial some new methods to try to build these factors and considerations into our deliberations when we ultimately arrive at a decision about whether to support a technology or not. Next slide, please. Of course, central to our work is stakeholder engagement, both internationally and nationally. And in the last year, we've continued to make contributions in the global stage and through a regular engagement with our Canadian, Australian and New Zealand partners through a memorandum of understanding where we collaborate on topic referrals. So we try not to duplicate, we share methodological pieces, we collaborate on things like the sustainability work, and also in this period, we've continued to attend our international peer groups and present the work of HEW, which has been very well received. And also in this period, we've joined a new international network which focuses specifically on social interventions work. So that might be, for example, interventions to deal with gang violence within societies is one, for example, that springs to mind, and to learn what the new techniques are within these types of engagements. So it's been a very helpful new addition in terms of our methodological understanding and networks. Next slide, please. Of course, this is just a snapshot of some of our kind of a UK, Welsh and national engagements. We go to dozens of events over the year, but we're regularly promoting not only HEW's guidance, but also the benefits of evidence-based assessment more generally. And in this way, we also try to get topics from the ground up and encourage people to refer topics to HEW to inform the challenges that they're currently facing within the service. Next slide, please. So there's lots more I could tell you, but time is short. So if you would like some more information on HEW, then there's some resources on our website. And of course, I'm really happy to take any questions that you might have now. But I just hope that I've given you a bit of a flavour of the 24-25 annual report. And we really look forward to continuing to support care services to make best use of the evidence to inform decision making on behalf of the people of Wales. And in that vein, also, obviously, we're acutely aware we get lots of cancer topics, but we know how busy you are in Velindre in terms of the reprovisioning of the new cancer centre. And of course, we remain very open. If there are any technologies topics that we can help with, then we'd be delighted to receive suggestions from colleagues in Velindre, as we've often done in the past. So thanks so much for your attention and for the ongoing support that we receive from Velindre colleagues. It's very much appreciated. Thank you.
Thank you very much, Susan. Two hands were shot up. I think it was Vicky first and then Jazz.
Great.
Thank you very much. Thank you, Susan. I mean, the report is fantastic, and we considered it as well in Quality, Safety and Performance Committee, which met a couple of weeks ago. I guess for me, because there's so much content in there that is amazing, and that's based on your strategic plan, which is 21 to 25. Yep. There was no mention about perhaps the new strategic plan from 25 onwards. So I was just wondering if you could share with us how that's being developed.
Yes, of course. So actually we're in the final throes of developing that and getting it to public consultation. So our executive group signed off the draft, and the plan is it will come to the Strategic Development Committee of Velindre. We were asked to take a hiatus to align our next strategic plan with the 26 term of government period. So we extended the existing one from 25 to 26, and we've prepared one that will be for 26 to 30. Obviously, our remit remains largely the same, so it's broadly similar, but it has been refreshed, and we'll be sharing that with relevant committees very soon, and we expect to go to public consultation on that next week, and also out to our key stakeholders. We'll bring back that take on board comments, make any modifications that we need to, then share it with the Strategic Development Committee, and we aim to publish that in March of next year. Apologies, I should have mentioned that. I'll share it ASAP. Thank you.
Yes.
Yes, thank you, Susan. I mean, a great report from you again, but also demonstrating the strengthening of engagement and impact that Health Technology Wales is having, not just in Wales, but actually across the UK, and some global impact as well. So it's just really good to see, and you've got the evidence to show that. And I think the expansion into kind of AI technology, artificial intelligence technology, and being seen as a kind of leader in this med tech ecosystem to set guidance is really, really important for us, because we all recognize that it's the direction of travel. And I think the example that you've given around, endoscopy assisted AI, which is actually improving, the sort of the ability to look for adenomas and the efficiency as well in the system. Kind of, we had a discussion earlier about cancer pathways impact, and the finance piece as well. And there's something about, because in that particular assessment, you demonstrated the improvement in efficiency. I guess but you've also flagged the difficulty in adoption of audits because of finance being a barrier. So there's something, I guess, about how we tackle that, and how do we unlock the efficiencies and tag that with the finance piece, and how do we actually put that money and reinvest that money back into the system, I suppose. I know we can't solve it here, but I think you are making a very important point in the report with respect to this.
Yeah, I mean, I think the one thing I will say is the AI topics are fascinating, and we're learning as we go, but it's really been incredible. And what's interesting, of course, is that although it's very much perceived as a new thing, the evidence is still very much catching up. So we've had a couple where we've said yes, and we've had a couple where we've quite clearly said no, because the evidence just isn't quite there yet. And I think that is important, to send that messaging to the service and to put the onus on the developers to bring that evidence forward, to make sure that they're good investments and they are actually delivering improvements for patient care. Now, the resource issue for the first time this year has come up, and so of course we're flagging that to government, because we expect that will of course ultimately impact on the service's ability to adopt some of these new innovations. Something that we are trying to do, and we'd really welcome, is we've always had disinvestment in our remit as well. And this year we have been given this remit from the CMO to look at, for example, things like the interventions not normally undertaken list across Wales. There are 125 things on that list in Wales, but only 14 of them common across all of the boards. So we're trying to work through that list to say, what are the things that, based on the evidence, we can say, please stop doing this, to free up that resource and to make some headroom to reinvest back in the newer things. Because rarely do people ever want to stop doing anything. It's just human nature, isn't it? They always want to keep things in their toolkit just in case. So we do welcome disinvestment topics, and we'd really, really be very grateful to receive any if you have any. So just keeping awareness of that, making sure that people are aware of that. But I think as well, having that all Wales picture, so you can actually see, are any inequities emerging? So are certain technologies being adopted quicker, or in the north versus the south, east versus west? I think has been one of the big boons of this audit, is it gives that kind of a bird's eye that allows the service to benchmark against one another, but also to try to ensure that there is equity of access in these new innovations, which often can be expensive but deliver huge benefits. Thank you.
I am going to draw this to a close, because I think we could be here for quite a long time, but clearly there's a lot of work that we can do with you, Susan. I'm going to suggest we share your presentation more widely, and that the conversation continues outside this room. But thank you very much, and you've got some, really impressive results under your belt for the past year. So thank you very much for coming. And
thank you so much,
hopefully
colleagues.
we'll see you again.
Indeed, thanks ever so much. Please get in touch if we can help. Thank you. Bye bye.
Yes, thank you. Bye. So that takes us on to 4.2, which is commitments of expenditure NWSSP exceeding CEO limit. And this is a mixture of for noting and approval. Alison, are you with us?
We're just calling Alison.
All right.
Calling her in. Yes.
Oh, hello. Welcome, Alison. We've all read the papers, so you can take them as read. So the first is Fleet Modernisation and Optimisation Programme business case. You're very welcome to do an introduction, but I'm going to invite people around the table to ask any questions if they have any. Do you want to introduce this?
Thank you, Chair. Yeah, just a few words of introduction. So the main purpose of this paper is to provide Trust Board colleagues with a line of sight on the intended future strategic direction that Shared Services is going to take on its fleet replacement programme over the medium and longer term. So we're asking the Trust Board to note at this stage. The programme team sought approval from the Partnership Committee on the 14th of November because the future strategic direction of Shared Services falls under the remit of the Partnership Committee. We're not today seeking any commitment to expenditure or any procurement at this stage, but the next steps following approval would be the development of annual business justification cases. Those would also require the approval of the Partnership Committee, but the value of any one BJC in the future, dependent on the type of vehicles, the technology available at the time, the procurement process at any point in time in the future, could exceed £1 million. That, under the scheme of delegation, would then trigger a future requirement to come back to the Trust Board for approval on those individual BJCs on a case-by-case basis. And so to ensure that there were no surprises further down the road, feel it is appropriate to share with the Trust at this point in time the overarching PBC that, as I say, has been approved by the Partnership Committee. It is aligned to our decarbonisation strategy. There is an indicative value in the PBC, but as I say, it is a medium to longer term position. So that is not a commitment to expenditure by any means in terms of contractual obligation at this stage. I hope that clarifies things.
Diolch, Alison. Are there any questions on the paper, Nicola?
Thank you, Alison, for bringing it today. Just wanted to ask, is there a quality impact assessment that's been undertaken that's gone to the Partnership Committee with this paper? And because if it's going to come back here for further consideration, then we would need to see that as well. Thank you.
Okay, I'll make a note of that. I haven't got it to hand, so if that's okay, Chair, I'll double check on that point.
Thank you. Thank you very much. In that case, are we happy to? Matt.
Yeah. Thanks, Alison. Probably can pick it up outside of the meeting. There was just on one of the pages in terms of the actual preferred option assessment.
Okay.
On page 34, 58, it states that option 16 has the highest benefit cost ratio at 0.35. But I think it's actually option 25 that has the higher at 0.38. So I understand that that's only one aspect of the prioritization, because obviously then you bring in, but I just think that's factually wrong, that statement. I would just correct that. But I wouldn't mind talking to you outside about how then the three factors that you, I guess, have assessed, which is the cost benefit, but also obviously you look at the objectives that you set yourself in terms of the financial objectives and the critical success factors. You bring those three together, don't you, to select the preferred option?
Okay. So, happy to do that.
Yeah, and it's interesting the parallels between obviously this business case and our own the Welsh Blood Fleet one, and I wondered whether there would have been
opportunity
done together. But we'll see. It's probably too late now, but I mean maybe for the future.
And I think our colleagues in WAST are also working on a similar PBC. So maybe there is still future opportunity when we get to the BJC stage in terms of the procurement process as well. Yeah, happy to follow that up, Matt. Good suggestion.
Thank you.
Okay, great. Thank you very much. So a couple of actions to follow up there, and we are happy to note the paper. Thank you for bringing it to us, Alison. And the next paper is the GP Locum Hub Wales digital platform. If you could take us through this, please. And this is for us to approve.
Yeah, so this is asking the Trust Board to approve. So this is a digital platform which is hosted and managed by Shared Services on behalf of Welsh Government. It allows GP practices to post and book locum coverage across NHS Wales. It also captures data that is used for the purpose of the General Medical Practice Indemnity Scheme to ensure that all locums are covered by insurance before they carry out work in practices across NHS Wales. As you can see, the initial contract was approved by the Trust Board back in 2019 with the option to extend for 3 years. There was a change control notice agreed in 2022 because the opportunity to align with a separate GP recruitment system arose. We took procurement and legal advice at that stage and we aligned the contract. Recently, Welsh Government have confirmed that they now want us to extend the locum hub arrangements for a further 2 years. So to provide assurance, there's no risk to Shared Services in terms of funding. It's been fully funded and approved by Welsh Government. No risk, therefore, to Shared Services or to any of our partners in terms of a funding gap. It was considered by the Partnership Committee in the 14th of November, but the extension does now trigger that we need to come back to the Trust Board to make sure that you're comfortable to approve the additional costs associated with the extension, which is at £271,000.
Thank you. Any questions? Gareth, and then Nicola and Lindsay.
Ddim yn siŵr os ydi Alison yn gallu gweithio neu beidio.
Can you hear the translation, Alison?
I can't, I'm afraid. No. Oh, hang about. A pop-up's just appeared on my screen. Hang about. Let me.
Hang on, you can check the language on there.
Yeah.
There we go. Yes, perfect. I'm there. Thank you.
I am.
Diolch, Gareth.
Rwy'n edrych o dalen 6 o 9 yn y capel, ac mae'n cyfeirio at gyngor cyfreithiol sydd wedi dod oddi wrth Legal and Risk Services yn dweud bod yr estyniad yma yn dod o dan Public Contract Regulations. Ac mae'n ymddangos bod y cytundeb yma yn cael ei ymestyn, wedi cael ei ymestyn unwaith yn barod, ac nawr yn cael ei ymestyn eto. Ac sy'n ddiddorol i ni gael gweld y cyngor cyfreithiol yna, achos mae bach yn amheus falle ymestyn y cytundeb ddwywaith, ac gwerth yr estyniadau hefyd.
Okay, so my understanding, Chair, is that the original contract arrangement was permitting an extension of 2 years. What happened in 2022, which is where we sought the legal advice, was that there was another system that was being run in parallel relating to GP recruitment, and we absorbed, for want of a better way of explaining it, that arrangement into this contract. So that's what that legal advice refers to, was the ability to do that via the change control notice that was approved in 2022. The extension now, therefore, covers the sort of the 2 systems in one for the further extension for 2 years. So I don't know if that helps to clarify, Gareth. So we haven't before now extended the original contract arrangement. It is still the intention, it was always the intention to have an option to consider for 2 years. We're still at that point, but what happened in 2022 was there was an alignment of this system with another system. That's what that legal advice refers to, and as a consequence we're now extending the both arrangements by 2 years.
Gareth?
Cwestiwn, a dyn ni wedi cael cyngor cyfreithiol ynglyn â'r estyniad hwn.
The 2020.
On.
So that.
The one that's intended to be done now.
I'd need to double check on that, Gareth, because my understanding is in terms of the need to extend at this point in time, we did have the approval to extend covered off by the original Trust Board approval in 2019, whereas I think the reference to the legal advice is more around the alignment with the other system, but I can get the legal advice and we can look at that if that's what you'd like to see.
Thank you. That's really helpful, and I think that relates to the fact that obviously the trust is the legal entity. So I think that would be helpful. So I'm not quite sure how we do this. Whether we approve out of committee pending that, or we approve here pending the advice. I'm not entirely sure what the route is. There are some more questions as well.
Yeah.
Nicola and then Lindsay. We'll take those.
Similar vein to my previous point, Alison, thank you. Because it's come to a decision at board, then we should have a QIA accompanying it. So I think it would be
okay.
We would need to see that as a board as well.
Yeah, and I'll check back what was done in 2019 when it might have come originally. So yeah, I can do that.
It wouldn't have been there, Alison. It's only
okay, fine.
Yeah.
So we can pick that as a point of order for future. I think that was my point of clarification, if I might, Chair, because obviously the expiry date for the arrangements is the 18th of December. So we will have to pick up with Non, if I could suggest that, in terms of how we might be able to proceed outside the meeting and link in with Gareth on his particular question. Yeah, diolch, thank you.
It would be absolutely at pace. Lindsay?
Yeah, I think I'm just trying to understand that the reasons which you have set out here, Alison, so I really appreciate that, but just to kind of hear a little bit more about that. So at this point in time, I'm understanding we wouldn't, for a number of reasons that are set out there, be in a position for a full procurement process. There's some more work that you're looking to have done in order to get to that point. And I suppose my point really is around assurance that we're not going to be in a similar position following yet another extension, that we're not ready, or you're not ready to take this forward as a wider procurement exercise and not coming back for a further extension. Just to get the clarity around that would be great. Thanks.
Yeah. So I think there are a number of sort of future dependencies that we're exploring. One is indeed what is Welsh Government's future priorities in terms of primary care sustainability, and this forms part of that overarching Welsh Government strategy. There's also the development, which some colleagues may be aware of the replacement for the electronic staff record. So there may be opportunities that we can leverage these existing systems into that new solution in the future as well. But I think, yes, I would agree with you that we wouldn't want to be in a position that we would be trying to extend this feature. We probably would have to go back out and test the market at the next stage.
Thank you, Alison. Vicky?
I think it's just to raise Alison and Vicky here, just about the timeliness of this coming to the board, because obviously the governance cycles, considering some of the questions that have come up, it would be helpful to all parties, wouldn't it, if it had come sooner, so that we'd have more time in a non-hurried way to address those issues. So I think just mindful of that for future papers into a procurement process.
Duly noted.
Yeah, thank you. And I think, we can refine this process, can't we? And get that better developed. So I need a little bit of help here on.
We will.
Yeah, I don't think we're in a position to approve yet. We just need that further information, clarification, and I think then, Alison, we can work with you outside of that, subject that to getting this formally approved. But I don't think we're yet able to, are we? Given the information, we just for everybody's benefit, I suspect. But we can work with you outside that, Alison, just to make sure that once that's provided, we can get to the end point within the timelines.
Thank you. Thank you very much, everybody. And the third item for approval is the procurement dashboard and contract renewal.
I'll take the paper as read on this one, and whether there's any particular queries or questions.
Questions or queries? Gareth?
Just i gadarnhau, pryd mae'r cytundeb presennol dod I ben, achos mae'n dweud ar y dudalen gynta bod e'n dod I ben yn mis Tachwedd eleni. Pwynt cyfreithiol yw, ydych chi'n methu ymestyn cytundeb sydd wedi dod I ben yn barod. Felly mae'r amseru yn bwysig fan hyn eto.
Alison, do you know the answer to that?
don't know the answer to that, so I will need to revisit that one.
So that's an issue of legal compliance, isn't it?
Yeah.
Yeah. Thank you very much. Well, I'm sure that's easily established. So again, if we can get that information. Non, did you want to come in?
Yeah, I'll liaise with Alison and James, make sure that the board has all that information as soon as possible so that decisions can be made in a timely way that's supportive of everybody.
Thank you. And if we could capture some of the points here, because as Alison says, you know, we can get a bit. Oh, John.
Say, as a new member, I read all the papers a couple of days ago, and I didn't see those two. Just again.
You didn't see those papers.
Okay.
And late this week, I thought, because I was in the same position.
Okay.
Maybe assessment.
There's a deadline for papers, so.
It should be 5 clear days before the meeting. Yeah. Yeah. We were working with James. I was working with James on the papers to clarify the position on some of the issues that we've raised. So, yeah.
So that there's another thing to add to a protocol that we might want to develop. Yeah.
I did think we had sent the papers across by the due deadline.
We were there, but there were queries following receipt of them that we were working on. Yeah.
No, thank you. Thank you very much, Alison, and thank you for your presentation. It was really helpful to all of us and lots of good pointers about future working. So thank you. There we are then. So we'll move on to committee escalations. And we start with 5.1, which is Public Quality Safety and Performance Committee Highlights Report. Vicky, is there anything particularly you want to draw?
The paper is read, and the issues that we escalated to the board's attention we've already covered in earlier discussion, so I'm quite happy to leave that. I'm happy to take any questions.
Thank you very much. Did anybody want to come in on that? No?
Just to add that we've attached the Q2 report with that, and if happy to take any questions on that, or if anybody wishes to have any discussion outside of the meeting on that really comprehensive quality report as well, which we've already covered quite a lot of that content already today.
Thank you, Nicola. And then the Public Strategic Development Committee, Lindsay.
Yes, I'd say very similar to Vicky, that take it as read, and the items for alert and escalate have been covered to some extent previously. If there's any questions around that, then I'm sure Carl can kind of answer.
Any questions? No, thank you very much. To note. So we now move on to item 6, which is items for consent for approval. We've got 2 items for approval and 7 items to note. And I presume some of these are national policies. So 6.1, again, taken as read. Sarah, is there anything you want to draw our attention to in terms of these 3 policies?
So just other than they're part of our regular review of policies, so this has come up in terms of the information is set out in terms of the needs for. So I'm happy to take any questions.
Any questions?
Lost about which we just doing the first 3.
6.1 smoke-free policy, adverse weather policy, and mental well-being guidance for employees and managers.
Okay, so it's on the adverse weather policy.
Yes.
Appendix 1.
Yes.
I don't think we should be leaving in NWIS as hosted organisation. It left us a long time ago. And if we're going to list hosted organisations, we probably need to put Health Technology Wales in. We probably need to put in some of the other ones reference.
Okay. Thank you. Thank you. So are we happy to approve the smoke-free policy? Yes. And the adverse weather policy with those corrections? And the mental wellbeing guidance documentation? All approved. Chair's urgent actions, none. We're going to hand over to you.
It's one for ratification. So it's a note to the decision made by the board.
Content?
Yeah.
Yes. And then we have a number of items, which is consent for noting. So I don't intend to dwell on these unless there are any questions. So I'll just run through them and see whether anybody has got any questions or queries. 7.1, Trust Seal Report. 7.2.
So Gareth.
Oh, sorry, Gareth.
Just ar yr adroddiad cyntaf yna ynglyn â sêl yr ymddiriedolaeth.
Ie.
Dwi'n edrych ar dudalen 3.
Dwi'n mynd ato fan'na.
Ac mae Carl James yw'r un sydd wedi arwyddo hwnna gyda chi. Mae Meic yn fel acting CEO. Oedd e'n acting CEO ar y pryd?
Ar wyliau.
Gyda o adref?
David was on.
David was on annually. Ie, ar wyliau. So dyna'r trefniadau sydd mewn lle. Dyna wni'n siŵr bod hynna'n glir yn y dyfodol.
Yeah. Diolch, Gareth. Anything else? No? So 7.2, Hilary, do you want to draw our attention to anything here?
No, sorry. No, I'm
Okay.
fine. Thank you.
Thank you. Diolch yn fawr I ti. 7.3, Local Partnership Forum Highlights Report. No. 7.4, Trust-wide Policy Approvals Update. 7.5, Strategic Partnerships Update. 7.6, Advanced Therapies Wales Programme Annual Report. No. So happy to note those, and then we go on to the committee annual reports. And we start with the Quality, Safety and Performance Committee annual report. Vicky, is there anything you want to?
No, take the paper as read.
Take the paper as read. So I don't have prior notice of any other business. Is there any other business? No. Thank you all very much. Thank you for your contributions today. I'm going to call this meeting to a close and ask you to adopt the following resolution. The board is asked to adopt the following resolution: that representatives of the press and other members of the public be excluded from the remainder of this meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest in accordance with Section 1(2) Public Bodies Admissions to Meetings Act 1960. Thank you all very much, and we'll be here again in January. Thank you.